and we operate as the key innovation arm of the NHS. We're catalysts of change, helping to facilitate change across the whole health and social care economy, improving health outcomes, driving down the cost of care and stimulating economic growth. Next slide, please, Anika. So we are in a really privileged position. We work across organisational boundaries. We connect with our regional networks and our regional colleagues, as well as linking in with academic health partners, health authorities, the third sector, commercial partners and businesses, as well as the public, and making sure our public voice is heard. And we respond to the diverse needs of our patients, our population, through partnership and collaborative working. Next slide, please. So we are one of 15, as I've said, and we're part of the Northern Network. So we work very closely with Health Innovation Manchester and North East and North Cumbria. And a lot of our work that we drive through is, especially when it comes to sort of patient safety collaborative work, which I'll talk about shortly, is about making sure that we standardise that practice across the country and reduce variation. So our footprint. We cover the whole of South Cumbria, Lancashire, Merseyside and Cheshire. We've got a population of about 4.1 million. We've got 22 NHS providers. There's about 600 GP practices, 1,300 plus care homes. We work across our 18 CCGs and about 96 PCNs. So it's a huge area that we cover, and that doesn't even touch on our supported living, our domiciliary care providers, and the work that we're doing across all of our NHS sectors: primary care, community, learning disability, and mental health and dementia also. So we host the Patient Safety Collaborative. Sorry, I'll go on to the next slide again, Anika, sorry. We host the Patient Safety Collaborative, and we are responsible for supporting the delivery of the National Patient Safety Improvement Programmes, which are a real key part of the National Patient Safety Strategy, which was launched in 2019. And then reviewed in the beginning of 2021 as well, with a review to this. And this is all about creating a safer culture and a safer system for our patients and for our workforce, and improving a culture in which we work in. So a culture that stimulates growth, stimulates learning, and a just culture where we think about fair blame and making sure that we think about the systems and the processes that we put in place are there to aid safety and not to hinder it. So there are 3 strategic aims to the strategy. So we have an insight aim where we're learning about the safety and drawing from intelligence from multiple sources, and gaining patient safety information. So learning from reporting and learning from excellence as well. The involvement side of it, so equipping patients and staff and partners with the skills and the equipment and opportunities to improve patient safety throughout the whole health and social care system. And this is where the new patient safety specialist roles will fall in, and I'm sure you've heard about them, the roles that, so each acute trust and community and CCG are required to have a patient safety specialist that are responsible for the delivery of the strategy, and the new patient safety syllabus, which actually goes live in October, so next month, where there is going to be learning around patient safety. So at the moment it will be it's sort of a trialling and a pilot, and then it will become essential, and they're hoping that this will become mandatory training going in the future. So it's a little bit off at the moment, but that's what it's going to be looking like. And then we've got the improvement arm, where we are designing and supporting programmes that deliver effective and sustainable change in the most important areas. So looking at the slide that's just popped up now, these are our National Patient Safety Improvement Programmes. We have 5 national priorities. It's all about continuous improvement and continuous learning. So our 5 priorities are managing deterioration, maternity and neonatal safety, medicine safety. We've got a new programme called mental health, and then the spread of adoption and proven interventions, and that's where the COPD and discharge bundles fit into. And we have several key enablers that help drive this improvement and help get it up the ground. So addressing health inequalities, ensuring that we build improvement capability within our workforce. We've got leadership from bottom up to top down as well, so that it's across the whole system. So we've got frontline staff providing leadership as well, and doing the work as done and walking the walk as such, and creating that safer culture. So next slide, please, Anika. Or Lauren, thank you. And so the key ambitions of the Adoption and Spread Patient Safety Improvement Programme, you can see there's 4 here. So the first 2 I'm going to speak about very briefly is making sure that we improve tracheostomy safety. And this was a really key ambition in a response to COVID, and delighted to say that we achieved this and actually exceeded this piece of work. That actually 94% of our trusts in the UK, so that's 192 sites, adopted the 3 key interventions. We're looking at emergency laparotomy care bundle in line with the NELA standards, and that's just being reviewed at the moment. And then we've got the COPD and asthma discharge bundles, which is what we're here to speak about today. And that's it from me, and I will hand back over to Anika. Thank you.
Thank you, Katie. So I just wanted to briefly give you an overview of our data. So we have a quarterly dashboard, and to request your dashboard access, you can email KSS-AHSN in order to access that. So we start with the national data. So we can see the national data currently split by each of the individual elements. So you can see the current information in terms of uptake, and the ACS level is what we are being the score that we are being looked at particularly. So we're about at 20% nationally. When we're looking at the Northwest Coast, so we've got the national average, the Northwest Coast being at this level. So we're slightly above average, which is great, but there are still elements of our care bundle that we need to be looking at. So this is across our Northwest Coast area, across all on our acute trusts as an average. So there's still a little bit of work to be done there. You can see we perform better, for example, with in terms of smoking cessation, but lower in terms of inhaler technique. But this will obviously vary according to the individual trusts as well. So I've looked at our national data over time versus including and then Northwest Coast data. So over time, you can see in the last few months, it's looking quite promising. Obviously, you've been applying a little bit more some of the QI work in terms of your teams, focusing a little bit more. So the uptake overall for ACS is increasing. So if we carry on along this sort of line, we are above average in terms of our PSC average. However, there are still some parts, if you look at the individual elements, that we could still be working on. And those of you that I've reached out to will be aware we've talked about some of the things that are going on within your individual trust. So what you need to prioritise in your trust may be different to another trust, obviously. And that's why we encourage you to try and sort of reach out to us and where we can support you if we can. So for COPD in Q1, 8 out of 11 trusts submitted NACAP data for Q1. So that's the data that's been coming through on the dashboard. And there have been common themes identified. So in terms of limited capacity, respiratory work not necessarily being prioritised at an exec level, time consuming in terms of retrospective checking of the patient admissions, inconsistency with recording certain elements of the care bundle. There's also potential for data entry error as well. And sometimes there's non or partial submission of NACAP data. So bearing all these things in mind, this also affects the NACAP information that's coming through. So for asthma, we have baseline data using our database for 2019 and 2020, but you will have more up-to-date data through your live dashboards. So we can see then for, on average, Innovation Agency, so our PSC is at 29% in terms of that was back in 2019-20. So that's compared to the national average, we were at that point slightly lower. But you can see that varies across all of the regions, really. Unfortunately, this is the only data we do have, so you will have more up-to-date data at your end. So back in 2019 to 2020, there was 9 out of 11 trusts that submitted data. And again, very similar themes have been identified with trusts more recently when I've been speaking to you. Sometimes you may not have a dedicated asthma specialist lead, or we've been able to identify them. And also the very similar issues as again for asthma. So that's why I've been speaking to teams about COPD and asthma together, and speaking to the audit teams together about COPD and asthma care bundles. So I'm going to hand over to Helen Beaumont-Kellner and Helen Carroll. So just let me stop sharing my slides.
Thanks, Anika. My name is Helen Beaumont-Kellner. I am from the Lancashire and South Cumbria part of the North West Coast Respiratory Network, and it's very nice to be invited here today. I will share my own slides. Have you got my slides, Anika, or am I showing my own?
If you can share your own, that'd be okay. Or Lauren has your slides.
It's all right. I've got it. It's fine. There we go. So hopefully you can see those all right. I'll just get a slideshow so it's easy for everyone to see. Okay, so yes, we are a relatively new team, and setting up a respiratory network in a region where there wasn't much infrastructure with regards to this network prior to us coming into post. So I'll just start off by who we are, basically. So we are a small team. There is myself, and we've got Leanne on the call today as well. She's our project coordinator. Dr. Ben Butler-Reid is our clinical lead, and he's just moved into post with the NHSEI as a deputy medical director. He works under Gareth Wallace. And we have our business support as well, Susan Booth. So our team was literally established between last November and this May, so it was quite a long period of establishment, that. And I just wanted to touch on very, very briefly our sort of governance structure behind where we sit. So we basically report into the 7 regional SROs and then into the respiratory delivery boards. I report directly as well to the National Respiratory Team and into the Respiratory Board via Jan Vaughan. So as I touched on, we're quite a new network, and we're very much establishing ourselves. We're going through the process now of all the building blocks of getting to know the exact stakeholders that need to be involved in on which projects, and looking at which projects that we're going to focus on, which are feasible and have the most impact on the health system. We have a variety of, we have 6 work streams with a long-term plan, but one of our significant work streams is long COVID. And our first project, so to speak, when we came into post, was to set up and facilitate the long COVID service in Lancashire and South Cumbria with our lead provider, Lancashire and South Cumbria Foundation Trust. That work is ongoing, and we came to a point in May this year where we needed to start focusing on respiratory and addressing the backlog. So we literally split our time between long COVID and the long-term plan objectives. So the other areas that we're looking at, obviously, pulmonary rehabilitation, which links quite nicely in with the COPD and asthma bundles, breathlessness, meds management, inhalers, flexible learning, community-acquired pneumonia for children and adults, early and accurate diagnosis, and we're involved in, but not pushing, the prevention programme. So our first large-scale change project is the PR project, and we've started workshops bringing together 8 disparate teams across Lancashire and South Cumbria, and our aim is to create a PR community sharing good practice and enabling transformation across our health and care ICS. So that basically means, in English, that we have got everybody together in a workshop. They have the opportunity to meet each other for the first time, sharing their pathways and discussing their current and future plans. So we have a lot of work to do there, and what we've got in the diary at the moment is 6 workshops taking us to sort of January, February. We're working very closely with the North West Coast IA, which is fantastic, and we plan on following through with evaluations, possibly going on to 23-24. We're not in a rush here. We're going to get this right, and we want to make sure that any changes to the pathways include all the stakeholders from an end-to-end pathway perspective, and we want to make sure it's sustainable as well. So as part of our PR work, the COPD and asthma discharge bundles is a big part of that as well. So we'll be working closely with Anika and Katie on that to see where we can support you. I mean, looking at you when you were presenting the data then, Anika, you could see, couldn't you, with the COVID period, which was a huge drop, wasn't there, in any activity, because obviously it was very difficult for the teams to focus on anything else apart from beds and the crisis. But there's always work to be done, isn't there, ensuring that the teams and the wards are following the asthma bundle, asthma and COPD bundle, and actually referring to PR and making that a forefront of their mind. You know, I would like, gosh, can you still see my presentation?
Yes, we can. Yes.
Sorry, I don't know why it's just disappeared. There we go. And it sounds rather political, but I love it if we could have, you know, if it was mandatory, if all discharge included a mandatory PR referral, that'd be fantastic. But obviously, we're not at that point yet. So that's PR for now. We are encouraging the teams to sign up for accreditation to make sure we're all sort of meeting the similar standard across the ICS, but we're working with a PR SAS who provide that accreditation at the moment to kind of introduce a little bit of flexibility. Touching on breathlessness, we're going to be working with the Cardiac Network. The national team are working on a pathway as we speak, so we're literally waiting for them. There's no point duplicating work to see what this pathway looks like, and then we're going to be pulling together with the different health systems across the cardiac and respiratory network. So hopefully that will start in November. With regards to meds optimization, this is rather exciting, but an area which we need to focus on is the environmental impacts of respiratory and how we can reduce our actions to help the environment. And it's not just about switching inhalers from MDIs to DPIs, it's about everything from reducing appointments to reduce the transport and the impact on air pollution. Recycling schemes, it's quite large, and as part of our next respiratory board meeting in October, that's going to be our main theme. It's going to be environmental impact of respiratory. So we're very lucky. We've got a very proactive consultant physician, Catherine Pryor, who's drawn up a model for her version of greener pathways to do with inhalers. And we're also working with a public health registrar on the current status in Lancashire and South Cumbria. So yes, I've touched on the rest. I'm conscious that I'm thinking about time, so I'm going to go to my next slide. So I've touched on this already. As a respiratory network, we are very much in the building blocks of making sure that we are working with the right people. So as part of the PR project and looking at research as well, we're linking with all these different groups. That includes, the ARC, NICE, CRN, personalised care, making sure we're linking with the NHS at home, objectives 2 and 3. We would like to drive a very proactive digital agenda in Lancashire and South Cumbria and make sure that we're working with the voluntary services organisations on the ground. So if we find a model or a pathway which works really well in one ICP, we would like to then roll it across to the other ICPs, encouraging the ICS approach. So we're literally starting meeting all these different groups now. And social prescribing, I'm very keen to make sure we adopt as much non-clinical pathways into our clinical pathways as possible, supporting our workforce. So where are we now? Well, this doesn't say very much, does it? Because there's so much to be done. So respiratory is such a large area. We're sort of very much focusing on specific things. So as per national team directives, we are addressing the backlog. So looking at sort of helping our PR teams address the waiting lists, which will link in nicely to our optimal PR pathways, looking at how active the patient is and offering the menu of options. Spirometry restarts has been a big focus. We now have an SOP which has been released to all the primary care PCNs across Lancashire and South Cumbria. We got numbers there, wait lists and average numbers there as well. So we're supporting the teams behind the scenes. Data-wise, it's early days for us. We would like to build obviously dashboards and support the teams remotely. So we're working with the various different groups involved in that and looking at sort of remote data extraction too. And funding wise, we've been very lucky. We've been gifted £10,000 from the North West Coast IA to help us with the PR accreditation first year fees for the teams. We have a small amount of funding to increase the spirometry training to the same level, ARTP, that's a £20,000. What this slide doesn't show you was that we've also had 2 separate payments for long COVID to help the community teams manage the long COVID patients as well, which equates to about £500,000 at the beginning of the year. That monies also went into the assessment for PR and various other rehabilitation teams. And the long COVID money for treatment is currently sitting with Blackpool CCG. That's 2.6 million, which has been split across Lancashire and South Cumbria, including the lead provider to help with the treatment side of long COVID. That includes diagnostics and onward pathway referrals. So there's quite a lot of money being managed in the background as well. And obviously,
sorry, Helen, we've got 1 minute left.
Yeah, that's fine. This is my last slide. Obviously, we can't talk about asthma and COPD or any respiratory network without touching on hospital admissions. So unfortunately for us, we are above average with our asthma and COPD prevalence in England. And some of our CCGs, again, are a little bit above average, but they're non-elective hospital admissions as well. So these are the, hopefully, with positive implementation of projects, we will make a difference to. Thanks very much, Anika.
Thank you, Helen. And over to Helen Carroll for Cheshire and Merseyside, please. Is Helen here? Helen Carroll?
Oh, are you on mute, Helen?
She's on the call, isn't she? I can see her listed.
Helen is here.
Hi there.
Yeah.
Hi everybody, sorry about that. I am here. I was having a few problems. Yes, I'm the clinical network coordinator for the respiratory team in Cheshire and Merseyside. The programme manager is Tracy Keats. Tracy unfortunately can't make the meeting today because she is on annual leave, but she's asked me to attend just to feed back to her really. So I haven't got anything prepared this morning. So if it's okay with everybody, I will put a selection of slides together and send them on to you if that's okay.
That's fine. Thank you, Helen.
All right.
Thanks for attending today. Okay, so we're going to move on to a patient perspective. So we're quite excited. We produced this video with a COPD patient and a carer in the North West Coast area. And we'd just like to share from a patient perspective and a carer perspective their experiences of, sorry, I'm going to have to go and share that now. I need to put the sound on. To share their perspective really of when they come out of hospital after discharge, what their experience is. So hopefully, can you see that, everybody? Or Lauren, can you see that?
Yeah.
Okay, I'm going to play that now. I'm not sure why.
Does Ian want to play?
No. And I did test this out this morning. Right, okay, let me just stop that. Apologies. Do you have a copy of it, Lauren? Maybe if you share it at your end, maybe it might help.
Yeah.
So what I'd just like to say about the video is it shows the impact and the worry that a patient carer goes through in their experience and looking at recovery at home.
Worry about him all the time, and so especially when he goes into hospital, I worry about will he come out, how's he going to cope, and then I always find that he can't do anything at all, so I've got to be hands-on all the time really. So it's hard for me, and when
I'm wondering if people could
easier.
take themselves off video, perhaps that helps.
Yep, I'll start the video again as well. Hopefully give it some time to buffer.
For me, I worry about him all the time. And so especially when he goes into hospital, I worry about will he come out, how's he going to cope, and then I always find that he can't do anything at all, so I've got to be hands-on all the time really. So it's hard for me, and when you're getting a bit older it doesn't get easier.
I was diagnosed in my 40s with COPD. So I've been a long time. I'm in my 70s now, 73. So I've had COPD for a long time.
Do you know what caused it?
Smoking, yeah. Can't really give any other excuse. I'm alpha-1 antitrypsin deficient as well, which obviously makes you more susceptible to lung disease. It's a strange feeling living with COPD. I think fear is one of the greatest things, which people don't really seem to, they concentrate on how it physically is, but you're constantly worried about things. You know, I'm worried that if I come downstairs, will I be able to get back upstairs? If I go out anywhere, will I run out of oxygen? If we decide to go away overnight, will I get there? And when I get there, will I be all right and be able to enjoy myself? So it constantly being fearful. That's the most challenging part of it. Coping with the physical effects. I suppose you learn to find ways of coping. being on oxygen now is the latest thing. That's since the turn of this year I've been on constant oxygen, and it has helped. But of course it restricts you as to how far away from your oxygen supply you can go, and what you can do. My admission to hospital is usually caused by an exacerbation of my COPD, and it is at such a stage that the best line of treatment is to get into hospital. So it's usually by ambulance. Or at my own request or at the request of the GP or the respiratory care team, and I'm taken into hospital. You always think when you're taken into hospital, I'm going in, am I coming out? You always are worried that this is the final visit, that you're actually not going to recover. You're not going to get well enough to get back out of hospital. It's the greatest fear.
You worry because you're worrying, is he going to come out? Is he going to be worse? And that's very hard.
Everything about it is not nice. I mean, the toilets aren't nice. You can never sleep properly. There's noises going on at night. You're woken up. You might have just managed to get to sleep, and you're woken up because the nurse wants to take your readings, your saturation, and so on. So you're woken up for that, and you have to get back to sleep again. You're worried about the sort of information that you're going to get. You very often don't really get information as you should do as to how you're progressing. You ask the nurse, and the nurse says, well, you have to ask the doctor. But the doctor never comes. So it's no fun, and it is not the sort of place to be unless you're a pushy person, and you don't like to be labelled as a pushy person. But if you're going to find out anything, you have to keep pushing and asking, and that's very hard to do when you're feeling so poorly. I've never really had a treatment plan coming out of hospital. The most information that you tend to get is your discharge letter, which has very little information really about how you're going to progress in managing your disease. So there is really very little of a treatment plan put forward. You get very little in writing to say what's the next step and what's going to happen, who's going to give you that next step.
Nobody's ever asked me about John's treatment plan, so I don't know. It's normally he might tell me after, but I don't know. The nurses will talk to me on the way out when I ask them things, but I really don't know what the plan is. He knows more of his own medicine, thank goodness, because he's quite good with managing his own medicine.
You'll find on your discharge letter that one of your medicines has been stopped, but it won't explain why it's been stopped, just that you're no longer taking it. And if it's a blood pressure tablet that's been stopped, you wonder why. Well, is my blood pressure now so good I don't need the tablet? Nobody's explained that to you. It's just left as, well, you're no longer on that tablet.
Well, when he comes out of hospital, obviously, I like to know the nurses are keeping an eye on him. I like to know that he's getting home care, because I think that's important, because it's frightening for me, because I can't handle it if he takes a bad spell of breathing or something. So it's nice to know that we've got home care, which I think you need after.
It would be nice if you had a pack that told you who'd treated you, what was the outcome, whether you need to have further x-rays on what date, so that you have a proper written pack. and you can give that as well to whoever's acting as your carer, because they can then understand what it is that's going to happen, and they can be there as a support.
What I think would be really good would be when he comes out of hospital that I get a treatment pack, that I know what's happening, instead of me going to have to ask him all the time, that I can get more involved then. So yes, I think a treatment pack coming out to me would be helpful to the other person.
I don't think people really do have any clear and concise discharge information. I think all they get really is a discharge letter and maybe a list of medications, and that's it.
At the moment, I rely totally on John to know what's happening, where I would like the information directly to me as well, so I don't have to keep asking him questions, because I have to keep asking, well, when do you take this, and what do you want me to do, and things like that. So it would be nice if I had the information, that I didn't have to keep asking questions all the time. So yes, I'd like more information.
Thank you, Lauren. You've got to love the tech sometimes when it doesn't work. Basically, the video was produced to show that the importance of care bundles and discharge care bundles in particular for these sorts of patients. It's a traumatic experience. The recovery continues at home, and having a discharge care bundle and having information would really help a patient and their carer to manage the condition at home, but even more importantly, reduce that risk of readmission. So please use this video in training. We will send out a link to it, and you're welcome to use it in your training with your teams if you wanted to. We'd really appreciate if you could spread it wider as well. Okay, we're going to go on now to Katie, who's going to talk to you about the QI methodology. So I'm just going to share my screen.
Thank you, and this really will be a whistle-stop tour through it really, but yeah, just a massive thanks to John and Viv for sharing that story with us, because it takes a lot to be able to share a story that's going to be shared so widely as well, but to give a real honest account of what it feels like to be a patient and a relative. So I'm just going to give a very quick overview, if you can go on to the next slide please, Anika, about quality improvement and its importance. Now, we either love quality improvement or we hate it. It's a little bit like Marmite, and those words either get you really excited or they put the fear of God up into you as well, and actually what is it that quality improvement can have to do with healthcare. And when Paul Battledon describes this as the combined and unceasing efforts of everyone, all healthcare professionals, patients and families, researchers, to be able to make the changes that will lead to better outcomes, better system performance and better professional development. It's the use of methods and tools to continuously improve the quality of care and the quality of outcomes. And in healthcare, it really requires an understanding of not only QI methodology and the science of improvement, but also the concepts of change management and what that desired future state looks like. So it could be complemented with many other tools as well. Next slide, please. Why do we need it in healthcare? Because as healthcare professionals and social care professionals, we don't have the time and the resources to spend on the things that don't work and that don't serve our patients and our population, but also that don't support our staff and give them the safety to be able to do their jobs effectively. And these things, you know, all quality improvement can do is help drive that improvement and efficiency as well, so that we help deliver safe, timely, equitable care that is patient-centred. And we need ways to identify how things work and what changes make improvement and the reason why this is. These ways also need to be really straightforward and effective, and the tools and technique of sort of quality improvement provides us with those skills and those insights. So just looking at this slide here that's just come up, when we talk about methodology, it's not just QI methodology, it's understanding the culture and the context which help to create the right conditions for a successful project. So that safe culture of learning, a culture that allows staff to raise concerns and to report incidents so that we can learn from them as well. And so that we know that actually we don't want a no blame culture, but we definitely want a fair blame culture, so that actually people do have accountability for their actions, but actually learn from them and there isn't a fear of being able to report. Having QI cycles, so small cycles of change, PDSA, so that plan, do, study, act, those small tests of change and maybe one patient to start off with that we can then roll out into a bay and then into that wider population as well. And these really guide us through the project implementation. So then looking at patient involvement, really important that we involve patients from a very diverse backgrounds, and Anika will talk about that a little bit later, and the importance of health and inequalities. But as healthcare professionals, we often think we know what's best, but actually we need to get that patient insight, as John and Viv have highlighted earlier. Understanding how to engage with not only our patients but our workforce as well, to provide ideas on how we can involve people and get the best out of the care that we're delivering and the service we're providing. That improvement science, so the model for improvement is as a proven model that we use, and I'm not going to talk about this today because I want to talk about something else. And what I want to really talk about is the importance of human factors as well, and that the understanding of the context that we work in, how we as individuals function in those spaces, but also how the systems and the processes and the equipment that we put in place can either accelerate or hinder care. So if we go on to the next slide, human factors and ergonomics. So Catchpole describes human factors as enhancing clinical performance through an understanding of the efforts of teamwork, tasks, equipment, workspace culture, and the organisation of human behaviour and its abilities of its application of that knowledge in clinical settings. And it's really about understanding how these all link together. So when somebody makes when an error occurs and an individual is often blamed for that mistake, do we ever look at why that happened? Could it be that I could go into work and give somebody that wrong medication as a qualified nurse, and that actually Emma could come in the next day to do exactly the same thing? Have we actually looked at the processes that we've put in place, and have we actually looked at what's happened? Could it have been that actually the wrong drug was prescribed to start off with? Is it that hasn't been checked then at the pharmacist at a ward round? Is it then that actually the electronic system that we're using isn't user friendly because you have to go out of the patient record into a medication review setting? So actually, what are the systems and process, and where are the loopholes that things can happen, and where is it that we can mitigate to stop these errors occurring? So what I'd like to introduce you to is something called the seeps model, and I have to say that this is my most favourite model of all time, and having used this for the past couple of years. It's a model that's got a human factors approach to it. So it's looking at how we can enhance that clinical performance with the understanding of effective teamwork and tasks and equipment and workforce, the culture of an organisation, and the impact that also has on human behaviour, and the ability for us to be able to work in those clinical settings. So if we look in the work system, we're looking at the people that we're working with. Who is it that we're working with? So it's our patients, it's our carers and their families, our health and social care support workers. What are the attitudes? What are the assumptions? What do we think that's happening? For example, if we think about our COPD care bundle, when a patient's being discharged from hospital, do we actually know who's checking an inhaler technique? Do we know whose responsibility it is to make sure that somebody might have an emergency discharge back? Do we know whose responsibility it is to refer to PR, and is that actually happening? Or are we making those assumptions that somebody else has got that designated role? So have we walked the walk and understood what that is going on, what the process within our organisation, or have we just assumed? What is the culture within our organisation? Where is COPD and asthma care prioritised? What is the infrastructure? What does your team look like? Where is it from a priorities review? What does the audit look like? Is an audit a priority within the organisation so you can see improvements? And also, where's the training and the education as well? The task that work is imagined, work rather than work is done, for example, process mapping, understanding those steps, where are those clinical and touch point steps between a clinician and a patient, for example. What is the complexity and the ambiguity of that task? What does it look like when you're delivering the COPD discharge bundle, for example? Do you have a sticker in that goes in notes to remind you of or to do a tick box to say it's been done? Is there a form? Is it on an electronic health record that's easy to access that everybody knows about? Do we have the tools and equipment there, and the technologies and the internal and external factors? Is this a national mandate? Is it hospital policy? What are the reporting systems and learning opportunities? Then thinking really about the processes, so the professional work, the clinician's responsibility for the patient, the roles and responsibilities, and the interactions and touch points. That collaborative work between patient and care and clinician as well, information exchange, those shared decision making points, instructions and advice that are given. And then what is the patient's active participation in this, in self-management? Where is that role as well to self-manage? And then looking at outcomes as well, those desired outcomes and those that we don't want, those unintended consequences. And we have outcomes that we want for patients, but also from an organisation and for professionals as well. So we're thinking about our patients, it's that appropriate and gold standard care has been delivered. That gives an increased confidence in self-management and helps reduce the chances of readmission into hospital for that same condition. From an organisation, you're looking at less readmissions, you're looking at improved retention and improved sickness rates, improved staff satisfaction, improved morale, which will then have an impact on a reduction in safety incidents. And when we're looking about professionals as well, it's understanding what's in it for professionals. So that ability to be able to have further education and training and to develop, and again, that will have improved staff satisfaction. So it's really understanding what sort of methodologies and how we think about the care we deliver. So don't just look at it as the role in which you're there to do on that day, but how we can also interact with our other healthcare professionals and our colleagues and our patients to get the best, and taking that system approach to it, to what's actually happened from a step-by-step process and doing a bit of journey mapping. It's quite a lot of information to give, and I could do a whole day on this, but I just wanted to give a little bit of a snapshot, because part of our role is within our organisation is to help build QI capability within our workforce. And I just thought a lot of us have seen models for improvement, and we hear this a lot. This is just another method and thinking about how we can embed human factors and think about the systems and the processes that we're working in as well. So it's just a little bit of an insight, and we will go into more detail in this another time, but very conscious of time at the moment. So it's just a bit of a snapshot really. So thank you, and happy to take any questions in the chat box, and hopefully we'll have a bit of time for some questions later also. Thanks.
Thank you, Katie. So we're going to move swiftly on to Kent, Surrey and Sussex AHSN, where they're going to be talking about using the dashboards to guide QI projects. I'll stop sharing my screen.
Thank you, Anika. I'm just going to share my screen. Sorry if it looks like I'm looking the other way. I've got two screens and it's a bit disorientating. Oops, sorry. Sorry, let me just get the right one up.
I have them as well, Ellie, if that's easier.
That might be easier. So I'm so sorry. We're in the office today for the first time, and it's all very confusing.
No, don't worry. I'll show you slides for you.
Thank you. And then Tom will share his screen for the dashboard demonstration.
There we go.
Thank you. So hi everybody. Thank you for having us at your network meeting today. My name's Ellie Mason. I've recently got married, so my name is previously Ellie Wells, and I'm the Respiratory Programme Manager at Kent, Surrey, Sussex AHSN. I'll let Joe and Tom introduce themselves as we work through the slides. But just to say, we work as a team at Kent, Surrey and Sussex. We've got a long-running respiratory programme, and we've been focused on the COPD discharge bundle in particular for quite some time. So we're going to share our experience with you today of the work we've been doing in KSS. Joe's going to talk a bit about the discharge bundle measures and good practice care points, and then Tom's going to do a dashboard demonstration for you. So I'll hand over to Joe now.
Hi, thank you for having us. So I'm Joe Conlon. I'm a respiratory consultant by trade, and I've recently been doing an integrated respiratory care job, working between primary care and secondary care and the community respiratory team, and I would encourage these take up of these posts in all your areas, because I think that the bundle, although it's measured in the acutes, it's really a whole system. It should be thought of as a across organisational boundaries. So we've all got responsibilities for providing it, and that's very much the approach we've taken in Kent, Surrey, Sussex. So I'm speaking here as some clinical lead for the KSS AHSN respiratory network, and we've been running this project for several years, and really encouraged people to come from all areas from primary care to from the community teams, multidisciplinary. So that's one thought. I've been here for the beginning, so I saw how recently your measures have really shot up. So there's a lot that probably you know already. But if we just have the next slide, please. So I think although the audit is the kind of the tick box measure, it's actually what's really important is giving good care to patients, and the audit should be used as a tool, I think, to drive better care. So what we don't want is someone going up to bed and say, can you use your inhaler? Yes, tick. And so, you know, we've talked about in our network and got people to suggest how to make this more meaningful. So we actually had it broken down a bit more into patient can demonstrate use of inhaled therapy and no change needed. Patient could use inhaler, but they needed coaching and change of technique, or patient unable to use inhaler and needed a new inhaler prescribing. So it's trying to kind of make these meaningful. Thinking about suitability for pulmonary rehabilitation, there's an interesting paper recently published which showed that if the person delivering the discharge bundle was involved in pulmonary rehabilitation, to maybe someone in reaching from a community team, the take-up and the referral rate to pulmonary rehab and the take-up rate was vastly improved. So thinking about different ways of doing things. And then just the appropriate follow-up call. I think that there is something about consistency of recording, and the measures have been sort of updated in the NACAP database. And if the teams have made the referral to a named person, that's counted as that being made. They don't have to chase whether it's actually happened. Obviously, we do want it to happen, but it's about processing. I'm going to stop there for the COPD and just if there's any questions about those measures, because sometimes things come up. Can't see any, so we're just going to the asthma bundle. So this is taken directly from the NACAP, and again that follow up, and that there's some more detail on the actual NACAP when you enter things. So you know, if someone's already got an appointment in place at the specialist, then that's a yes, that's been done. So sometimes teams sort of do themselves a disservice by marking themselves down, but it is the correct care given. And one thing that's very much emphasised, and it kind of refers to your patients video, which I thought was a really great thing to do, was about there's a statement about no person admitted with asthma should leave hospital without a personalised asthma action plan. And so that's a really important thing to do. And I think, as you've really sort of alluded to, the key in successful bundle delivery and achieving the project aims is having a system to identify patients, sort of real-time entry of data, and a mechanism so that the patients are seen by a respiratory specialist. Now that may be a physio, it may be a specialist pharmacist, it's often respiratory nurse specialist, but it can be different people, and having that system ideally more than 5 days a week. So I'm just going to stop there, and I don't know if there's any question about the asthma discharge bundle elements. Okay, we'll move on.
You're on mute. Right, Ellie, can you just mute yourself? So, yeah, ongoing issues. Ellie and I are actually sat together today. Right.
It might just need to be that the sound's off rather than the mute.
Cool. Right. Hopefully that's now sorted everything. So thank you very much for inviting us back. I think it must be about 2 years ago since we met some of you in Cheshire, where we were able to first give a demo view of how the dashboard was coming along as we were developing it, in essence, to launch the national COPD discharge bundle program. And so a fair bit of time has passed since then. And so we are aware that we've got new team members involved in the program. There will be trusts who weren't able to attend a couple of years ago. And so the Innovation Agency team has asked if we could give a brief demo on navigating the dashboards, how to interpret them, and then just discuss any sort of caveats to the data. So if I share my screen here, I'm hoping that everybody can see that now.
Yep. Can, yes, thanks.
Right, so if I get going. So I'm aware that teams will have had access to the dashboard previously, and quite recently we had to undergo a bit of a sort of infrastructure change, and so the web URL which teams will have access has changed. So if you want to regain access to the dashboard, if you previously had it, there's an email address to contact, which I'm sure Katie or Nick can circulate after the meeting. But once you've gained access, you will arrive at a view very similar to this, which sort of details the challenges and the aims of the program and discusses a bit about the data flows. And then what we've tried to do with the dashboard is build several different views to sort of cater for all sorts of people, all sorts of different data literacy. Not everybody's got a PhD in statistics and maths, and so we try to keep it in simple places, and also offer those who are really into their sort of data analysis some slightly more enhanced views as well. So what we're looking at here is just a very high level national overview of each of the discharge bundle measures for a given period. And you can filter this further down into a specific month should be interested. And along the top here, we've got a list of PSCs and trusts. And so today we're interested in Innovation Agency for the Northwest Coast. And the charts change, and you can do a bit of a deep dive. From here, you can also select a specific trust. So if you're more interested in seeing your own data, and then from there, you can kind of weigh yourself up against what was the national average for a period of time selected. And this is just supposed to be a really sort of high level and easy to understand snapshot view for a given period of time. But that doesn't always necessarily help when you're trying to do your quality improvement program and you want to be able to measure the change over time. So if I make my way over to the individual trust time series, this is where we get a good understanding as to how each of the different discharge bundle measures are being delivered, and where you can start to measure your sort of improvement journey over time. And so we've got data in the dashboard from the beginning of 2019, and that goes all the way up to July of 21. The 6 measures down here should be recognizable to most, and Joe has just discussed these. And then what we've got at the top here are some sort of just aggregate measures to understand as a whole how the bundle is being delivered. And so what we've got is the appropriate care score, which is a measure to understand what percentage of patients received every single measure which they were eligible for as recorded in the audit. And so if you had a patient population of 10 patients in a month and 1 patient were to receive all measures of the discharge bundle, you would have an ACS score of 10%. But sometimes not every single measure of the discharge bundle is given. Trusts may have policies regarding the emergency drug pack. There may be reasonings because of the appropriate follow-up. And so it may be that a trust never gives every element of a bundle to a patient. But that doesn't mean that they're doing poorly with their discharge bundle. And so what we've got here is the composite quality score, or the CQS as we refer to it. And this is a measure to understand of all the measures that a patient was eligible for, how many did they receive? So if we had a patient who was eligible for 5 measures and they were given 4, that patient would ultimately have a CQS score of 80%. And it's important just to to review the CQS score versus the ACS score, just to understand where those gaps are in delivery. Getting a fair bit of feedback. So this is the view that you'll arrive on default, and again you can then select your specific region. So here again we will select an innovation agency, and then at this point what you can do is you can then see how your region is trending versus what would be the national average. And this is useful for sort of regional leads to be able to see how they stack up, but it also means that when you select an individual trust, you're able to view again how you're performing versus your regional average, but also how you're performing against your national average. And from there, you can then try and liaise with other trusts in your region to see if they've got any sort of tidbits or pieces of best practice which you could try to implement to sort of improve your discharge bundle delivery. I think when we just look at this, there's a few caveats to the data. As we know, COVID has come along and caused issues with data quality. The audit was no longer mandated to be completed while still promoted. And so we have seen a significant dip in the number of cases being reported onto the audit. So that causes sort of deep sort of dives in the data with regard to individual bundle measures, and you can see they're quite tightly aligned to whenever we've had a peak with COVID. And I'm aware through discussions with Katie and with Anika that the Northwest has been quite heavily influenced for a sustained period of time by COVID. So it's always just worthy of taking into account the fact that there are fewer patients being reported in the audit when you look at the most recent month's worth of data. And this is just because we're looking at percentages. And so a smaller population means that your percentage swings could be far greater on any given month. And so you just have to sit back for a moment and just think, how many patients am I putting through the audit? And is this what is causing sort of large swings month on month in my adherence to the discharge bundle? When you start filtering down into sort of more granular level details and you've got individual trusts, your view may become littered with red stars. And this is so that we can maintain small number suppression, which is required when you're doing sort of these analyses using sort of big national data sets, and it's to protect patients. We don't want to be able to identify patients. And so if you start seeing red stars, you've then got to ask yourself at this point, am I a service which sees very few patients, and so the data is quite likely to be suppressed because I've got a very small number of patients in my service, and I'm giving the bundle to most of them, but it's not greater than 5. In which case, your adherence is actually greater than what the dashboard can actually tell you, but we still got to appease those data necessities. Your data may also be suppressed if you're a large service, but you're not consistently delivering the discharge bundle elements to patients, or at least that's what's being reported on. And at that point, you then got to do a bit of a deep dive. You've got to think, are we not delivering these elements? Or is it a case that there's something going wrong between our auditing process and us doing the delivery, which is meaning that the data just is not reflecting what we believe to be our delivery of the bundle. So there's plenty of different avenues you have to take this when you're just looking at the data. If I just continue on, for those who really enjoy data, we've got our typical sort of box plots, so you can weigh up regions, and we've got SPC charts. Again, they've been quite heavily influenced by COVID, and so a lot of the time the process is apparently out of control. We're trying to find workarounds, but then we've got sort of more simple views such as bar charts again, so that services can compare how they are doing between regions, try and buddy up with a region or a trust who's doing particularly well in an area, and then just try and share that. And somehow I'm hearing Pete. Oh, right, I know why I'm hearing Pete. I'm sat in multiple meetings at once. So this is the COPD dashboard, and as I say, those of you who attended the meeting last time around, a couple of years ago now, may be quite familiar with it at this point. Recently, the NHSI Commission was extended to also include asthma. And asthma as a program at the moment isn't quite in the position that COPD is. We're still working with Rachel and NACAP to get the data sharing agreement put in place, and that's being led by NHSI. But as a program, we needed to understand what our baseline position was, because we didn't really have too much of an idea at a national level. Fortunately, and a big thanks to Rachel here, the clinical audit for 1920 asthma was put on dodata.gov. And what this allowed us to do was to start to develop a baseline and understand for each of the hospitals in the country, again, what their sort of asthma discharge bundle looked like. And we were able to sort of turn that into a static picture so that PSCs who are supporting trusts and the trusts themselves can identify from their 1920 data where there was gaps for improvement or gaps to interrogate further to understand whether something's going wrong with auditing. You can navigate this dashboard slightly differently. So at the moment, we've got a big old map. And what is currently showing as default is the percentage of patients which received all measures of the discharge bundle. But using the bundle measures on the left here, you can select the different ones and it will influence the chart on the right. A map isn't always necessarily very useful, so similar to the COPD work, you can filter the chart on the right to be a bar chart by region, or you can take this further and you can filter it by a bar chart by hospital, which looks quite chaotic until you have it filtered on a specific region. And then at that point, you can then start doing that sort of deep dive, and you can compare yourself to regional trusts, see where you can steal bits of best practice, liaise with each other, and put together a bit of a plan.
Sorry, Tom, just 1 minute left remaining.
Yeah.
Thanks.
Well, this dashboard isn't being updated at the moment because, as I say, this is just a static picture. We are working with NACAP and NHSI, and the aspiration is that we have something close to the COPD tool so that teams can start doing that more, a deeper dive into their time series data and start really getting on with their quality improvement programs. Did you have anything further you wanted to discuss, Ellie?
I can share the slides after.
Okay, then. I've waffled about dashboards for too long, so thank you very much. If anybody's got any questions, please just pop them in the chat or email me, Ellie, and we're more than happy to pick up any queries. Thank you, Anika.
Okay, thank you so much for coming today and introducing yourselves and how you can use the dashboard. It's really important. I've put a link in the chat about how you can sign up to the dashboard as well, and we encourage you to do so. Okay, our next speakers are from the NACAP National Asthma and COPD Audit Programme, so Rachel Andrews and Natasha Long.
Hi, Anika. Thank you, everybody, for inviting us to join you today. So Tasha, if you could share your screen, please. Thank you. So we are briefly going to take you through the key aspects of the NACAP data set, in particular the discharge bundles, because we know this is what this meeting is focused on today, and how to get the most out participating in the NACAP audit. Next slide, please, Tasha.
Sorry.
Yeah, so very quickly, introduction, so Anika has just done that. So I am Rachel Andrews, I'm the Deputy Programme Manager for NACAP, and my colleague is Tasha Long, who is the NACAP Programme Coordinator who specifically supports the COPD and pulmonary rehabilitation audits. And why we're here today, so it's just participating in NACAP is a benefit to you and your patients, and being able to enter data into the web tool accurately is a big part of that. And we're here today to help you with some of those aspects of the web tool. So this very much touches on Tom's point as well, that the better quality data that you can enter into the NACAP web tool, and the more data and the better quality data, it just helps with the greater improvements in care of your patients. And obviously that's reflected in your NACAP run charts, it's reflected in your your bundle web tool dashboards that Tom's been presenting to you as well. So it benefits everybody. So what we're going to cover, so I appreciate that you're here to talk about discharge bundle in particular, but Tasha is going to briefly touch on some of the other elements of the web tool as well, just for completeness, particularly those elements that align to national incentives and RQI targets. So for adult asthma, that's very much around peak flow, systemic steroids, respiratory review within 24 hours, and then your discharge bundle and the specific elements of practice care. For COPD, I'm just going to briefly talk about the new inclusion criteria changes that came in for patients discharged from April. NIV, spirometry, respiratory review within 24 hours, current smokers and prescribing of smoking cessation, and again the discharge bundle and specific elements. Tasha is also going to take you very quickly through setting up custom fields. So obviously we have a set data set that we collect and use, but that doesn't mean that you can't collect other data items and have those reflected in your data set on the NACAP web tool. Thanks, Tasha. So the COPD inclusion criteria, so just to take you through this quickly, this changed for patients discharged from hospital as of the 1st of April onwards. So we added in, so there's a summary table here that kind of shows you what codes are now included where. So we've added in an emphysema code in position 1. We've also asked that any patients with the COPD exacerbation code, so that's J44 and J44.1, will also in position 2 are also included in the audit, and then also your J22 and R06.0 are included in the audit as well. So this has been done based on feedback from audit participants themselves, national organisations and key stakeholders and expert coders, and some new research which has shown which are the best ways to identify patients eligible for our COPD audit. On the whole, we recommend you stick to this inclusion criteria, but if you have any concerns about including specific patients, please do get in touch with us. So handing over now to Tasha, who's just going to quickly take you through the web tool and some of the specific elements that we collect.
Hello. So I'm going to start off by right at the very beginning showing you how to log into the NACAP website. So you start by going to nacapp.org.uk, which brings you to the home screen, and you've got your 4 boxes. To log in, simply click visit on the audit that you want to go to. Type in your username. I'm going to log in as a user for today. And just because we're going to be looking at both audits, I'm going to quickly log into the adult asthma audit now, just so that we've got that ready when we need it. So starting with the COPD audit, firstly, I'm just going to highlight this nice big announcement that we've got on the front page about the V3 dataset that applies to all patients discharged on or after the 1st of April. That's this one here. And any patients discharged before that date should still be entered into the V2 dataset. As we're going to mostly use the V3 dataset going forward, that's where we'll start. And as you can see, your first page is the inclusion criteria. But as Rachel said, if you have any questions, please do get in touch. So we're going to start from arrival because your NIV is 2 hours, your NIV measurement is 2 hours from the time of arrival. So you really do want to get your date and time of arrival in so that your NIV can be accurately measured. Moving on to admission, because all of your other time-bound measurements are measured from admission. So respiratory review and steroids or beta agonists and things like that are from admission. So you want to get that date and time in as well. For respiratory specialist review, that's within 24 hours of admission, and you'll see that you've got little information boxes that give you the quality guidelines and statements they align to, and a little bit of info about the overall question. And then if there's an information box next to the actual question, that will give you a bit more detail on answering the specific question. So in this instance, those staff members that would be considered a respiratory specialist for this purpose. So if you tick yes, you just enter in your date and time. And for respiratory review, the validation on the web tool will not allow you to enter a date or time prior to admission. So if the respiratory review is conducted between arrival and admission, just use the date and time of admission or within 1 hour of admission, just to record that that has actually been done within the timed period. As I said, NIV is within 2 hours of arrival rather than admission, and there you'll just see a bit more information about the guidelines and standards to which it relates. And again, if you say yes, date and time. On to spirometry, you want to add the results of any tests and the date they were recorded, and it's question 8.2 that informs your run charts and is related to the QI target. So that's the one that you definitely want to have completed. Going to skip comorbidities because they have been removed, and onto the discharge bundle. If the patient was alive when they were discharged, just the date of discharge for COPD. And then with regard to the discharge bundle, we're aware that some services will use the BTS version of a discharge bundle and other services will have their own version. That's absolutely fine, as long as you have evidence. So as I think it was Katie was saying before, if it's a sticker, if it's notes, however you record that the discharge bundle was provided, as long as that there is objective evidence of that, you should tick yes. If the patient was self-discharged, or if a discharge bundle wasn't fully completed, you still can select those aspects of the discharge bundle that were provided during the admission. And moving on to the elements of the discharge bundle themselves, you'll note that smoking cessation is currently greyed out, and that's because we didn't select either current smoker or not recorded in the patient information. And you'll see that now I've done that, that is now highlighted. With regard to smoking cessation and pulmonary rehabilitation, these are not things that you can force patients to take. So as long as you have discussed the benefits of these with patients and given them all the information they need to make a decision, even if they decline, you should tick that those were provided. With regards to the follow-up request, there's a little bit of an information box about that here, and essentially again, if the patient has been provided with that information, to make that request within the 72 hours, you should tick that that was provided. You can see that we've got a custom fields tab here, and I will go into more detail on that in the adult asthma audit. Again, a bit of a whistle-stop tour. There are a few differences between the COPD and the asthma audit. First of all, there's only the one data set. And second of all measurements are measured from arrival rather than admission. So you definitely want to get your date and time of arrival in there. Additionally, acute observations are all in one, and acute treatment is all in one tab. So for acute observations, it's peak flow that informs the run charts and is the QI target. And there's a little bit of information there on calculating peak flow or on answering the questions. And so if you say yes, again, date and time. And for acute treatment, again, respiratory specialist review within 24 hours of arrival. And again, that information on those people who can be considered respiratory specialist staff. And again, systemic steroids, beta-2 agonists, if they were provided within, I think it's within an hour of arrival, and if they were provided steroids prior to arrival. Again, onto discharge, which is very similar to the COPD discharge page, except we also want the time of discharge. Again, it gives that bit of information here about the objective evidence of a care bundle and gives you the various options that you might use to record that. And again, so if they had all the necessary elements and that's evidenced on the on the patient record, you tick yes. Yeah, just select the relevant elements that they received. Again, with the follow-up request, if the patient was provided that information to make that request themselves, they you should tick that. If they have been made an appointment for or given the is already being seen within a secondary care clinic within the next 4 weeks, select that. And again, with tobacco dependency, if that's highlighted and you have offered the patient that option and they have declined, you should still tick that element. And so onto the custom fields, which you can see in the adult asthma audit, we have a couple of things that you may want to add. And you can literally add, I think it's up to 15 or 20 additional fields, but do think before you add them, because once they're added, you have to contact the web tool to delete them. And so how to create a custom field is fairly simple. So you go into your support page and you'll see on the left here you have custom field options. Click on create new field. Field label is just the name that you're going to give the field. Field name here, I leave blank. I think it's just the total number of fields that you have created, so just leave it as it is. This is the type of data that will go into the field, and if you select drop down, you'll just want to put little new bits of data for each line that you want to offer. Now, for include this field in your records, when you're first doing it, until you're absolutely sure that you want to include it as an option in your records, click no and you can save it as that. And then once you're absolutely sure that you want to start collecting that data, click yes, save again, and it will appear in your data set in that custom tab. The field order I just leave as it is because, quite frankly, it doesn't seem to affect anything. I've done multiple things with it, and I used to think it would change the order of the questions on the page, but apparently not. And just the final field help note is for if you want to leave a note for anyone who is completing the data set, just to give them instructions on what to do there. And then once you're happy, you click save, and that is then saved. And you can edit and click yes, and it will be added to the data set. And once you have done that, that will be saved in this custom tab, and there would be a new question underneath there. And that is a quick whistle-stop tour of the audit web pages. I'm just going to go back to my presentation because what I do have are our top hints and tips. Oh, we've gone right back to the start. Here we are. So I've got a summary of our hints and tips. It's all about your time-bound measurements and when they're from, the validation on the respiratory specialist review, and some general information about using the audit and those elements of the discharge bundle that are optional. Oh yeah. And then there's just some information here, sorry, about audit guidance and where you can find further information on how to complete the audit and or get in touch if your questions aren't answered via the resources. And I think I'll hand back to Rachel now.
Thank you. So I think Anita shared our most recent versions of the audit guidance with you all. Obviously, take some time to go through that, digest it, and if there's anything that you're coming across that isn't included in those, please let us know. They're now all available on the web tool in the download on the web tool on the download section, so you should all have access to that via the web tool as well. Next tab, Tasha. Next slide, sorry. And just a tiny bit about reporting from us, that what you can expect over the next 18 months. So your run charts will continue to run. They are real time. They'll update every hour, I believe. So they'll just continue on a continuous basis. We're starting to produce regional reports again from December this year. So they'll provide a summary of performance on key aspects of care every 6 months. And then we're going to have a combined report which is going to cover all aspects of all of the clinical audits, published in January 2023. Our organisational audits are starting to run now. So if you haven't, so those of you who are working in adult asthma and COPD services, you should be conducting this at the moment. If you haven't heard anything from us, please get in touch, because it's happening now. So we need to support you in getting that started. Yeah, and the regional reports now at NHS region and ICS level as well, which we hope you'll find helpful. That was from stakeholder feedback that we got. Next slide, Tasha. Yeah, so any questions? I'm really aware of time, so if you have any questions, you can either put it in the... Oh, we have a hand up already. Anika, are you happy for us to...
Yeah, that's fine. You can take one question. Yeah, from Laura.
Hi, so
hello.
Laura.
Hi, can you hear me okay?
Yes.
Hello, so I'm one of the respiratory consultants in Liverpool and I'm the audit lead. So I've just got 2 quick questions that you might, about each of them, because I can't get onto the COPD audit. You talked about NIV and it being started within 2 hours of arrival. Is there some way to put on the form that, say, if they don't decompensate until day 2 or 3 of their admission, they're not decompensated when they come in, they don't need NIV? Can you put that on? Because it would look like you've not given it within 2 hours if it's later on, because not everybody comes in decompensated. So that was my first question. And the second one was about the for the asthma one, the 2-day community follow-up is something that we really struggle with. But are you saying that if we just verbally say to patients, you need to see somebody in the community within 2 days, that counts, that we can tick that box?
Yeah, I'll just stress that point first. So, so to tick that box, you either need to make a request to the relevant NHS organisation yourself, or provided the patient with the information they need to do it. If you've done those 2 things, you can tick the box.
Okay. Thanks.
The NIB, that's right. Yes, Tasha. Yes. So if you've done everything you can to set up to make that request, then you can tick that box as completed. For NIB, Tasha, could you just go back to the web tool quickly to have a look at the NIB tab? Because I believe we measure it, the 2 hours, for everyone who received NIB rather than all patients. So
yeah, but what I'm saying is, you know, some people come in and haven't got decompensated type 2 respiratory failure, but then on day 3, 4, I mean, it doesn't happen very often, but occasionally we do have patients like that. But then if you filled in when they started their NIV, it would look like you've not started it for 40 hours or however long till they decompensated. So it's just, is there something to negate that on there? Because
I don't think there is, if I'm honest.
There isn't in the audit itself, but you could add a custom field that would say, for example, if the NIV wasn't within 2 hours, you could add a custom field that say reason for NIV not being within 2 hours, and you could add a text comment that says patient didn't decompensated X hours after arrival. I think that would be a way around, because then you'll have that record in your data that you can export for your internal purposes. So when people are looking at it or saying, oh, you didn't have that within 2 hours, you can say, well, actually, that patient didn't decompensate until a day later, and that's why they weren't given that NIV until that point.
Okay, thank you.
Okay, thank you, Laura. It's just in the interest of time, there are a few more questions, I think, coming up in the chat. So if you don't mind answering those for us, that'd be great. Thank you, Rachel, and thanks, Tasha. So we're going to move swiftly on to Kelly Waterworth, who is the Integrated Respiratory Service Manager for East Lancs, and she's supported by Jen Swift, who's the Respiratory Audit Clerk. So thank you, Kelly.
Thank you, Anika. Thank you for having us. So I'm here to just share our journey, really, from an East Lancashire point of view. Is Lauren doing the slides? Next slide, please, Lauren. Yeah. So I'm the Respiratory Service Manager for East Lancashire, so I have operational responsibility for the Respiratory Nurse Specialist, the Respiratory Assessment Unit, Pulmonary Rehab and the Home Oxygen Service, as well as the audit. So next slide, please, Lauren. So East Lancashire Trust is quite a unique trust in that we're a large trust. We cover East Lancashire and Blackburn with Darwin. We have a huge ethnic diversity, a wide geographical area, and we have additional challenges with socioeconomic deprivation. We have a high incidence of respiratory disease in our area as well, so it makes it very challenging for us in this area. Next slide, please, Lauren. So this is really showcasing our audit journey. So we started in February 2017 with a best practice tariff at 16.7%. So we looked at that from a respiratory directorate point of view, how we could improve that. So we decided to audit everyone that was eligible for the audit to improve practice. We had respiratory directorate buy-in, so that meant our consultants were on board as well as our full respiratory team. We took the decision in, I think it was just after February 2017, to employ our own respiratory audit clerk, and I believe that's quite unique in the area as well. We used the funding from the best practice tariff to initially kickstart that, and then we took it on at risk to our own budget in-house. So from February 2017 to September, we did improve, but then we continued to improve in October 2017 because we opened the respiratory assessment unit, and that's again quite a unique area in East Lancashire. So that was for rapid admission for COPD, asthma, urgent consultant review, and we had GP open access as well for respiratory patients. So they were managed in a day case unit and then discharged either back into community services or onward admission. So we were able to really capture, that's when it really changed in our journey from East Lancs. You can see in June 2018, if you've got really good eyesight, to December 2018, we lost our audit clerk, so she went on somewhere else. So sometimes we're at the challenge, one of our biggest challenges really, where we've got a single-handed audit clerk. So if she's off or she goes elsewhere, then the audit really does suffer because nobody else is picking up that work. Next slide, please, Lauren. And then this is our audit results. Next slide, nice picture. Don't know them. So this is our smoking intervention slide, and this is showing our data that we captured. So this is our most recent data. So this is looking at smokers that we've discharged this year. East Lancashire do quite well in smoking referral and smoking cessation, and I think it's to do with the wraparound services we have across the two CCGs, as well as our respiratory nurse specialists. So our respiratory nurse specialists intervene early, so they can capture them again on the respiratory assessment unit, or they can capture them on the ward, and it's offered at every opportunity, and follow-ups then onward into the smoking cessation services commissioned locally. So this is where we identify, and we're well above the national average in this. Next slide, please, Lauren. So this slide shows the percentage of COPD patients that have been audited. So this is showing 82% of patients that have been audited with a respiratory review. This is a good result, and it's we average around 80% in this area. Apart from when we were in COVID, we dropped down to 60%. So the challenge in this slide is really to do with COPD and getting it identified at the start of the patient journey. As we know, COPD isn't always very transparent in either the medical records or coming through ED. Next slide. I do talk fast, it's the Irish. So this slide shows the percentage of patients that have received a review within 24 hours. We generally do okay with this, but there is obviously room to improve. Again, our respiratory nurse specialists work very hard in this. We have this area entirely ring-fenced in their work. So the respiratory nurses, along with the audit clerk, can look at who's about to breach, and then she can tell the respiratory nurse that's on for that day, targeted with the ward reviews, who to go and capture. It's not always perfect because we're not a 24-hour service as the respiratory nurse specialist, and we get obviously EDs and places like AMU, but we have tried to navigate this with a 7-day working. We've extended the respiratory nurse working hours as well, so we cover more like a 12-hour period rather than a 24-hour period, and we do prioritise that, but it still is a challenge for us here at East Lancs. Next slide, please, Lauren. So this is showing our discharge bundles and the percentage of successful discharge bundles completed. This figure's around 65%, and that's happily a pass rate for us. But it's noting that if we were to get to all patients within 24 hours that were suitable for referral, then our pass rate would have been 73%. So just to note, from an East Lancashire journey, we've had a discharge bundle way before the audit came on board. The wards used to fill it in or not fill it in as it happened. So now we take ownership of that. So the discharge bundles are owned by the respiratory nurse specialist department alone. It's not rolled out onto the wards. We own it, we keep it. There is room to improve. So again, we look at our respiratory nurse specialists, not some are better than others at filling it in or ticking all the right boxes. So we have got some room for improvement there. And we do have some occasional data collection issues with admin, staff sickness, things like that. Next slide, please, Lauren. So this is our overall graph that shows the current pass rate really in all our categories. So we are above 60% over the last 2 months, and we are slowly picking ourselves up from our journey in COVID. COVID's been a massive challenge for us because a lot of our services were stood down as well. Our nurses were redeployed because it's an acute unit as well. Our respiratory nurses were redeployed onto ICU, onto all the respiratory wards frontline. So our work did pay the price of that. And we also had our audit clerk. She left the post, then we got a new audit clerk in August 2020. So she joined just in the middle of COVID. So we had challenges around her going on to wards and things like that, and access and ED. So next slide, please, Lauren. So again, this is just summarising our audit challenges. Staff sickness, as I say, we employ a single respiratory full-time audit clerk. She is based on the respiratory unit here at Blackburn and then goes out to audit onto all the wards and works in conjunction with the respiratory nurse specialists. COVID, I'm sure everybody's sick of hearing the word COVID as a challenge, but it is a recognised challenge for us. And again, data collection, admin, just getting everything streamlined and all lined up in the one place for us is another challenge here at East Lancs. Next slide, please, Lauren. And just to look at quickly quality improvement. So we've picked an area that we recognised where we were falling down. I think we'd done some work with Anika as well on one of the calls, and Jen and I have been looking at this as an issue. Inhaler technique, I'm a respiratory nurse specialist myself. There is no reason why a respiratory patient should not have an inhaler technique coming through into a hospital journey. So I don't buy it really why we were statistically lower than where we should be. We're looking at how we can improve. So we're looking at inhaler placebos. When we questioned some of the nurses, some of the excuse was for not checking it. Oh, the patient couldn't find it. They didn't bring it into hospital. It was lost in the ambulance. Well, they should have placebos, and they should be able to demonstrate to a patient every type of inhaler. So we've addressed that. We've looked at the discharge bundle. So again, we find it a little bit clunky from a respiratory review point of view. So the nurses, as they're working down it, they felt like they were jumping around. So some of it they weren't filling in because they just thought, oh, I can't be bothered, or it's not in the right place. So they were ignoring it. So we're overhauling that, and that should give us successful results, hopefully in time. And again, post-COVID, we're picking up more referrals coming in within the 24-hour period. Next slide, please, Lauren. And that's me. If there's any questions, you can get in touch with me directly if anybody's got any thing they want to ask me. Obviously, they can put it in the chat as well.
Thank you so much, Kelly, for giving the truth of what's been going on there and the challenges, successes and challenges throughout the last few years. So thank you so much.
Yeah, we get little wins and little successes, and then some fails, some not so goods.
Okay, thank you. So we're going to move on to Knowsley Community Respiratory Team and Emma Rickards, who's a consultant respiratory nurse, and she's actually now our clinical lead for COPD and asthma care bundles. So welcome, Emma.
Hello, thanks for having me. Let me just share my screen. I've got 2 screen problems as well. It's bringing up my second screen when I do it. Have you got it, Anika, what I've emailed, just the NWAS 2021-2022?
Did you email it to me or to Lauren?
I emailed it to you.
Okay. Just a minute.
I've got several things open. I can try. If you can tell me what's come up on the screen.
Nothing's been shared yet, Emma.
Okay.
I have a Word document. Is that the one?
Yeah, that's it.
You want to share that one? Okay.
Yeah, please. Thank you. Because I haven't got a presentation as such. But so my name's Emma Rickards. I'm a respiratory nurse consultant. I work at Liverpool Heart and Chest, which most of you will be aware is a tertiary centre without an A&E. And I also work for Knowsley Community Respiratory Service. So we're embedded in lots of different projects in Cheshire and Mersey. And one of the things that we undertake as a service is we have an honorary contract with Wiston Hospital, where we have nurses, 2 Band 7 nurses based in A&E, who also go up to the AMU and GPAU to try and avoid unnecessarily admissions for all respiratory conditions apart from asthma, where we would want that patient group to be clinically stable before we would allow them to go home. So one of the things that we realised is that we've got a community service with a database of over 7,000 patients with COPD. And part of that service allows patients to ring us 24 hours a day, 7 days a week on an 0800 number, where with between the hours of 8 in the morning and 8 in the evening, we can respond within 2-hour period. But despite having that service in place, patients were still being admitted to hospital. And one of the ways that they were being admitted to hospital was via ambulance. So we did an audit for a 6-month period, which showed that 77% of patients were admitted via ambulance. So we thought, what can we do to try and prevent those admissions? So a couple of years ago, we had money from transformation to initiate a rapid response ambulance, which is a blue light ambulance, and it is initially was manned by our specialist respiratory nurses along with a paramedic. And in the first year, we had 542 contacts, and that resulted in 231 admissions avoided. 177 were respiratory in nature. It was only supposed to run for 3 months, but we extended it because of COVID, where it turned into the COVID ambulance. And then the next year, because of the success, we put in another bid and we ran the service again for a 5-month period, again during COVID. I don't know whether any of you have been watching Ambulance, but it was at that time that we were actually on the rapid response ambulance as well. So we had 477 patient contacts and 185 admissions were avoided, so less than the previous year, but that was down to, for a 2-month period, we were just working Monday to Friday due to staffing issues because of COVID, and also we were having to spend a lot more time with patients due to the delays and pressures on the North West Ambulance Service. And this service is going to be starting again in November, on November the 1st. So we're really excited to be doing that. But in addition, would we be able to go down to the bottom of the paper, Anika, just to the COPD virtual ward round? Just to complement this, we were, because of the success of our COVID virtual ward round, we were given an opportunity to do a pilot at Wiston Hospital using our current staffing model to implement a series of respiratory virtual ward rounds. So this was a really good opportunity to help other services within the local footprint of Wiston Hospital. So what happens is anybody that's got a diagnosis with COPD or suspected, and that's been a barrier to overcome actually. So we will still onboard them and refer to a local diagnostic hub. We will complete a referral form. So I don't know whether you've heard the Swiss Nurse. So we're based in A&E 9 to 7 every day and go to AMU. So we receive direct referrals from CareFlow, which is everybody's got an app on the phone to be able to receive the referral. And once the patient's consented, we give them a blood pressure monitor, SATS probe and thermometer, and they're followed up with Merseycare and given remote monitoring. and we inform the local COPD teams who undertake a day one visit on those patients. But for Liverpool and Knowsley, we're undertaking that day one visit. So how this relates into the care bundle is that even if we see, so every single patient that's been discharged home is referred to our nurses. So we have direct contact with those patients where we provide everybody with the COPD discharge care bundle. So what we do is we have a sticker that, as Katie alluded to before, we have a sticker that we put in patients' notes along with our input, where we tick the relevant things. We've added in a few things like COVID vaccination and things like that as well. And then we fill in the paper document. And at the minute, we're keeping them stored because we're under discussion about getting an audit clerk for Wiston, which I think has been okayed, to input both the COPD care bundle and the asthma care bundle, which will be starting in a couple of weeks as well. So what this means is that everybody between the hours of 9 till 7 won't get missed. And even out of hours, we're still accepting referrals on the CareFlow app. So if anyone's discharged when we're not there, we can still pick that up, and we're able to liaise with their local COPD teams or ourselves to be able to provide that. So it's a kind of a robust way of trying not to miss anyone. Obviously, it's not foolproof, but you know, it's a pilot, a 6-month pilot. So hopefully, if this pathway is successful, then it will be rolled out elsewhere. So that's the COPD. And just thinking about the video, it really shouldn't be underestimated the impact that we can have just on spending that little bit of time going through inhalers, you know, education, offering pulmonary rehab. And as the patient in the video said, sometimes he goes home and things have changed and he's not aware of it. So I think, you know, things like this, you know, it helps reduce mortality, helps reduce readmissions to hospital, just ingrains, you know, kind of when patients are supposed to be taking their inhalers. It's a lot to think about. And, you know, again, don't underestimate the, you know, the impact of being diagnosed with an irreversible lung condition. You know, you want all the help you can. I know that I would if it was, you know, a family member of mine. So with regards to the asthma one, this, if you scroll down a little bit, this is something that's starting in a couple of weeks. And all of these pathways, I've got the pneumonia one on there, but just ignore that for now. All of these pathways we developed with STHK, and then we actually put it out to the wider net of Cheshire and Mersey. So we had the clinical respiratory leads just to have their input about what we should do. So the asthma one, we've just simplified basically in line with what the NICE guidance suggests, what BTS and the MRAD report with the 24 to 48 hour follow-up. So we're going to do a 24-hour follow-up. So I think Laura asked the question before about how we're going to do that. So this is a pilot for Wiston. So what our service is doing, irrespective of your postcode, irrespective of where you live, in order to help reduce health inequalities, we will be doing a day one visit to anyone that attends the hospital. So obviously we are including A&E because from a personal perspective and our team, we feel that the MRAD report reflected that 43% of those who died hadn't had an asthma review in general practice. And I don't know what your thoughts are, but I think that might be because a lot of the patient group in our area work. They can't afford to get the prescriptions. They haven't got the time because, you know, there's a lot of deprivation in our area. So this is you know, if somebody's attended A&E with their asthma, we really need to be kind of embedding what they need to be doing, giving them their education. And it might surprise you to hear that just by undertaking a personalised asthma action plan, a patient is 4 times less likely to end up in hospital. So something as simple as that takes seconds, really can have an impact on readmissions. You know, the ideal is that you don't have any symptoms with asthma, and you know, we can all work together in trying to help that happen. So with the asthma pathway, what happens is that we do a day one visit, and then we are on board the remote monitoring, and it's only peak flow that we're going to be monitoring. There's not going to be anything else, and it's just to create an understanding and just that support network that you know, to monitor and empower patients to self-monitor and self-manage, you know, their asthma as well. So that's going to start in a couple of weeks, and like I said, this is a pilot, so we really want it to be successful and work, so then we can prove that these initiatives can be rolled out elsewhere. And that is all I wanted to say. Thank you.
That's great. Thank you so much, Emma, to basically sharing your experience of what you're currently doing, the pilots that you're doing in the area. You've mentioned health inequalities. That leads me nicely onto the next section. I was going to do a sort of a good sort of 10 minutes on this, but we're not going to have time. But Emma's also here as a clinical lead for the COPD and Asthma discharge care bundle work as well. So she will be available to support the trusts in our Northwest Coast area. So please feel free to get in touch with her as well. Okay, right, so I'm going to share, I hope it stops sharing. So I'm just going to briefly talk to you about the health inequalities in our area. So we've touched briefly on this for East Lancs and also for Knowsley. What does it actually mean? So we've actually within our innovation agency project, we've actually applied the health equity tool, and it's something that Public Health England have designed, but we've actually implemented it with our asthma care bundle work. Sorry, it's kind of all over the place here. So hopefully you can see my screen.
Yeah.
Thank you. So Public Health England have segmented the population into the health inequalities. So there's overlapping dimensions of health inequalities. We all fit into this, into one or well, many of these circles. And they split it out by socioeconomic groups and deprivation and geography, protected characteristics and inclusion, health and vulnerable groups. So it's been proof, and Emma's touched on this, within Knowsley, the most deprived areas, there's less access to services. There's people with health inequalities there because they don't have the time to access services, or they have higher mental health outcomes. So this all contributes to worsening health outcomes, and especially with respiratory disease, it's been shown there's a very close link with respiratory disease and worse outcomes with people with health inequalities. So those are the environmental factors. So poorer housing, high levels of worklessness, reduced income, high levels of smoking. And these maps show that where there is higher levels of indices of multiple deprivation, therefore there is higher, you can't see very well on here, but the darker the region, the significantly higher levels of COPD on GP registers and asthma on GP registers as well. And that's very much within our Northwest Coast area. So we've applied this tool looking specifically at the discharge care bundles and looking at things like protected characteristics. So for example, with race, there's with 85% of COPD, it's due to smoking, and there are higher smoking rates amongst Bangladeshi men, Irish, Pakistani and Black Caribbean groups. So we could automatically assume, therefore, that if you have a population that's higher with Black and minority ethnic groups, you will have higher levels of COPD as a result of that. So all of these characteristics do contribute towards COPD and asthma outcomes. I will send you this presentation so you'll be able to have a better look at it. And also finally for our inclusion health groups, so you need to think about the if they're homeless populations accessing your services, your trust, the GRT community, sex workers, vulnerable migrants and people leaving prison, because quite often they have worse outcomes, and especially for respiratory conditions as well. So what does it mean for discharge care bundles? How can we look at each element of the discharge care bundle, and how can it be tailored to individual needs? So we are talking about at the moment, this is sort of work that we can think about now, but into the future. Do we have the appropriate resources for people whose language is not English, or those with learning difficulties? Are we involving the carer or family in provision of information? This is very much evident in the video that we showed today. How are we involving the carer or family in that information provision when they're being discharged, as they are the people who are responsible for that patient and caring for that patient? Are we co-creating the plans with the patient and tailoring their management plans to their needs? So looking at their housing situation, for example, are they more likely to have a housing situation which is damp and therefore causing problems? Are we referring the patients to services which are designed to local population and patient needs? So I mentioned people whose language is not English, the first language is not English. Is that smoking cessation service therefore fit for them, and is something that they can access easily? And when we follow up with patients, are we sure that the format is suitable for them? So, for example, a phone call versus face-to-face, would that suit somebody who's got learning difficulties, for example, when they might it might be better impact as a face-to-face meeting. So on to our next step. So we have 5 minutes to go, so I'm hoping to finish on time. So what we'd like you to think about is familiarising yourself with the support that we can provide you. So that will be with myself and with Emma. And we have quarterly dashboard updates, which I have sent out to you. So I sent one at the end of August, and there's the next one due at the end of November. We have the opportunity to offer you one-to-one project management meetings, and we've already sort of met with quite a few of you already to support your respiratory and audit teams to focus on this methodology. And quite often I try and get the respiratory clinicians and audit teams together in one meeting so we can have those conversations, open and honest discussions. And then get familiar with your clinical lead as well. So you met Emma today, so we look forward to working with her closely in the future. So we'd like you to think about focusing on 2 elements specifically for the COPD discharge care bundle, which have the lowest uptake in your trust. So if you look and refer to your CQS data there to inform you, or you'll probably know already what this is anyway. What can you achieve over the next 3 months? So we've advised thinking about a 30, 60, 90 plan, but thinking about what you can achieve with those elements for the next 3 months. And then we've got our next collaborative meeting scheduled for January. So you're invited to report back on key achievements and basically let us know how you've been getting on. We'll be able to have a bit more of a collaborative working space for the next meeting where you were able to feed back to us and have something a bit more interactive. So finally, I said I would promote, also help to promote these learning collaboratives that were recently brought to our attention by NHSE and I. So there's one for being hosted by Wessex AHSN, which is a Pheno Learning Collaborative on the 12th of October. And then there's a link there for registration. And also there's a Primary Care Respiratory Society and British Thoracic Society event. It's a webinar series. And you can see the dates are between October and December, so you can sign up there. So I'll stop sharing. We do have a couple of minutes for any questions. Everyone's been quite quiet today, so please feel free to ask any questions you have now. Or we can close the meeting 2 minutes early.
I'm just waiting for some hands to come up. I'd just like to say thank you to you for arranging this meeting, and I hope everyone has found it as stimulating and inspiring as I have. And I think this is just the first of the meetings that are going to come. I think we've got some really exciting work ahead, and I'm absolutely delighted to be working with Emma Rickards as well and having your clinical leadership to help drive this forward. So thank you very much for that. And we will send out a 30, 60, 90 day plan so you can have a look at it. So it's just thinking about within your organisations, what is within your gift now? What is it that you could do? And I think it's not just thinking about it in the context of COPD and asthma, but actually helping towards our unplanned emergency care agenda as well. We're going into winter. This is going to be a really tough winter. We all know that, especially for our respiratory teams. So what is it that we can do to help reduce length of stay, to keep people safe within their own homes as well? With that management plan, we are in a world where COVID has really propelled remote working and that digital agenda of delivering healthcare, and we've learned that it can be just as safe as having somebody in hospital. So let's look at how we can, harness all that learning we've had over the past 18 months, take some of that learning and apply it to our work going forward to help keep not only our patients safe, but their carers at ease and comfortable as well, but also our workforce. We are an exhausted workforce, and we can't forget that everything that we're putting in place now has to be safe so that our staff feel safe to work within the areas that they are. And I say this as a clinician myself, to know how challenging it is to work on the front line, but to have support, to be able to have that clinical leadership that we've got within this room, that we can support on each other and use each other as a peer support to get through winter and learn from each other's practice as well, but also to be that peer support if you need anybody to sound off at. we're also here. I'm sure Emma will welcome that as well. We really are. And I think the other thing is just to highlight the importance of the respiratory network that we've heard from both Helens today that are working really well in both ICSs, both in Cheshire Merseyside and Langston South Cumbria, and how the work is all coming together now to really improve what we're doing in respiratory care.
I can't see any more questions on the chat, but I just also want to say a special thank you to Lauren Peat, who, if you want to show your face, Lauren, she's our events planner, so she is here when we need her. So thank you very much, Lauren, today. And we look forward to seeing you in January.